I do think that unfortunately there are a couple of issues that are so big and so dramatic that that we really kind of need to get the big picture stuff first. And to be honest, one of those is everybody deserves the same high quality care, right? If we don't agree on that, there's really not much more to say. So, because if you say that, oh well, people have to work hard their whole lives and be wealthy, and that's the reason you deserve to go to have good health care, it's like, well, it's not good enough, because we disagree on a fundamental level. I think the Susanna Fox principle. Susanna Fox continues to say, and she just mentioned this to me the other day, that she really has her greatest hits, the song that she's asked to play again and again, is this basic idea that patients should be treated as assets and not liabilities. Like, we need to stop thinking as patients as an inconvenience, but rather as part of the solution, and that patients are an untapped resource. And she says that again and again and again. And I think that's her drum. My drum is data should be used for patients and not against patients. And I keep hammering that. And I think the reason why we need to keep hammering these things is talking about diversity and talking about like getting all the best ideas from all the people. I think we're somewhat blocked by these kind of underlying value questions where it's just like we are not on the same page in terms of values. And I think there is an ongoing alliance that is made on a dynamic basis by the people who kind of give a shit in this industry and people who don't. And it's pretty easy to see who does and who doesn't. Like, so if I make the statement, the very high level statement, data should be used for patients and not against them. Well, the things that trickle down from that high level statement are, it's really unethical to do data siloing. It's unethical to treat your data as your asset for a payer or for a large healthcare system. It's not your asset to leverage. It is you're entrusted with that in the same way that we entrust our bank with money and we expect a return on that money. We should expect a return from the data that other people host for us and say, what research have you done with that? How many research have you shared the data with? Especially under the circumstances, if you're just holding the data and doing nothing with it, that's one thing. But if you're not holding data and you're selling the data and the data is being used to do profit analysis and to do financial analysis and do financial planning, and it's being exercised already, if it is not also being exercised for the purposes of social good and research and programs to figure out what the heck is going on, that's really problematic because that's an example of it being used. And I don't actually think financial use of it's not wrong. It's just not really for the patient in the same way that we would say. And so if you're doing only that, I think that is a form of using the patient data against the patient, because really what you're doing is you're using it to inform one side of financial transaction. And as the other side of that financial transaction creeps more and more towards completely unaffordable, it really is, you're just using the data against the patient. You're using the fact that you understand the big picture of the whole system in terms of money because of individual contributions to these piles of data, and then you're using that to go negotiate against patients writ large, and that's a problem. So I'm certainly not suggesting that you can't do financial analysis, and I help people do financial analysis on data. That's a good thing. It's a good start, but it must only be a start, right? You have to then also say, well, who is curious about this data and would want to see exactly the same data who's working on a hard clinical problem? And so I also don't think you need to wait till we get these big problems solved before we start asking and checking in with people. But in some senses, I think it's almost a litmus test that I use, because it's like, if you don't agree with me on like 3 or 4 issues, I'm not going to talk to you about diversity, and I'm going to talk about health equity, and I'm not going to talk about these things, because it's like you're almost playing a different sport. And I think for those of us who are playing the sport of really reforming things and really changing things and really empowering patients and really making sure that we do a better job taking care of people, well, then those people can be reached with a message of, hey, why don't you include some researchers? You are including researchers? Great. Why don't you include some researchers from, I don't know, a historically black university? maybe they have a different perspective on the healthcare system than yours, or from Tel Aviv University, or from another country, or let's do a collaboration between us and Sweden, or whatever. It really doesn't matter, as long as you're constantly asking the question, what more can we do to get a different perspective and use that diversity of thought to ensure that we're not missing critical things. Because the irony is, and I think this is a profound insight, it might be the community that you don't think very much of that provides the clinical insight that cures the disease that your community has, right? And so when we think about rare diseases, I think this is the classic example, the rare disease community has answers in their suffering where we will learn things from them that don't help with their suffering, but because we try, we learn things about our major diseases, and we learn things about how things really work. And I think that's a perfect example of how we need to be exercising diversity of thought to attack these harder problems.
What do you do on your end to enhance humanism in medicine through the use of data?
Oh, it's interesting because we have this phenomenon where if you're looking for the knowledge and the evidence that makes a difference to a single patient, you need to look at 10,000 patients' data. And so what you can very easily do in my shoes, and I think a mistake that some people in my profession make, is to think, well, unless I have 100,000 data points, it doesn't matter. But there's a virtuous cycle that needs to occur where people come together to put their data together, so that we have pictures of what happens to large populations. And by understanding those trends and trend analysis and doing data analysis on those kinds of things, we can create things that make the individual's data interpretable and meaningful. So in some senses, I think we should never take the individual out of the lens as we zoom in and out of kind of thinking about populations and peoples and individuals. And it's something that it's very hard to keep an individual in your mind and to keep it to keep that perspective, especially as you zoom in and out. And I've got to be honest, when I interact with patients, the interaction that I have with patients as an informaticist is as a row on a table. And we spend a lot of energy trying to ensure that we see that row as a table as a person. Because it's hard, because it is just to us a row at a table. We'll never meet the people we will never meet the people whose data we are looking at, and we will also never meet the people who benefit from the analysis that we do that helps us understand those people. But that doesn't mean we can't hurt them if we do it wrong, and it doesn't mean that it's not important. So we are absolutely 4 or 5 steps away from the patient, but it is difficult. Your question is a hard question, and I don't want to pretend like it's not a hard question. Is how do you be a data analyst and continue to see other humans in that data? It's a challenge, and it's difficult.